So this is a really important topic, and thank you very much for asking me to speak about it. And it's something that I've sort of increasingly started to pay a lot of interest to, given this new focus on thinking about paediatric rheumatic diseases across the life course, rather than just focusing on childhood. So comorbidities, I think, are increasingly important. So conditions like GIA, lupus, JDM, all the pediatric rheumatic diseases, although you might think of them, really involving the joints, the muscles, and the bones, maybe the skin. We know that over the longer term, there can be additional impacts that maybe we don't tend to focus on quite so much in childhood. And due to all the fantastic treatments, the biologics, all the different treatments that we now have access to, children are living much longer, they're leading much healthier lives. And the challenges that we're facing are maybe switching a little bit to sort of some of the longer term challenges. And that's what the focus of this talk is about. So what comorbidities are, why they happen, and what we can do together to try and prevent them. So comorbidities are essentially a health problem that happen alongside the main condition. So you might have GIA, and you might have another condition, and that other condition would be a comorbidity. And types of examples of this would be things like if someone sort of either during childhood or later on was to develop heart disease, was to develop infections, things like osteoporosis, like thinning of the bones, or mental health issues. So they're all sort of in addition to that sort of main primary healthcare problem. It's not guaranteed that people will suffer from these problems, but increasingly we're recognising that these are a problem, and that if we just remain sort of focused on that primary health condition and ignore the rest, then we're not doing the best for our patients. So the risk of these we're becoming more aware of the risk of these things, and we need to be proactive about trying to address these types of conditions. And the reason that they happen, so a lot of paediatric rheumatic diseases are characterised by inflammation that happens over a long period of time. And what we're trying to do with our treatments is try to get that under control and to try and keep it under control as much as possible. But often conditions can have sort of flare-ups, and it's very difficult to sort of keep inflammation under control completely over the longer term. And we know that inflammation in itself is a risk factor for things like heart disease. So what do I mean by heart disease? I mean like longer term risk of things like heart attacks, also other cardiovascular disease like strokes, things affecting the blood vessels, thinning of the bones, and difficulties with the immune system, in addition to the problems that we have with our joints, muscles, and skin. It's very important to keep that inflammation at as low a level as possible to sort of prevent the risk of that condition itself on the joints, muscles, and skin, but also on some of those longer term effects. We also know that a number of the medications that we use have side effects, which we try and minimize the use of drugs that have the most side effects, and try and move on to drugs that have least side effects. But sometimes those side effects can also lead to comorbidities. So particularly thinking about things like thinning of the bones, and osteoporosis is a well-known side effect of steroids, for example, that we try to avoid being on over the longer term. Comorbidities might happen because of the disease itself, but they might become worse or more of a problem because of things in people's lifestyle. They often, transition can be a difficult period where there's a lot of change, and that can also sort of fuel these types of things. And overall, being aware of these comorbidities, although they might sound a bit scary, I think it's better to have an awareness of them, to think about them, to put in sort of small changes in a conscious way to try and prevent them, rather than just try and treat them later on down the line. So focusing on cardiovascular health, so talking about heart, but also the blood vessels that deliver blood to all different parts of the body. So we know that when there's a lot of inflammation, that blood vessels can suffer from that. It can cause irritation to the inside of the blood vessels, and over a really long period of time, that irritation can lead to things like atherosclerosis that you might have heard of and think about in adults, where there's furring of the arteries, and this can cause things like heart disease and strokes and things like that. And we know that in children, from things like doing special scans of the blood vessels, looking at the flow of blood across the blood vessels, looking at the thickness of the blood vessels, that in certain conditions, particularly ones where there's a lot of inflammation, that blood vessels are affected. The things that we can do to try and counteract that are, one, obviously controlling inflammation. Two, keeping a close eye on blood pressure. So blood vessels don't like it when people have got high blood pressure. It puts a lot of strain on them. And over a prolonged period of time, that can cause, furring of the arteries as well. Cholesterol, so fat levels in the blood, excessive cholesterol levels can also impact on blood vessels. Activity is really important because for a number of different reasons, but in this context, it helps to bring down your blood pressure. So exercise helps to reduce your blood pressure. In adults that have got high blood pressure, the doctor will often recommend doing more physical activity. That helps to treat it. It also helps to have an effect on cholesterol and bringing down cholesterol, which furs up the arteries. So activity is very important. Diet, again, avoiding too much high fat, too much red meat, and avoiding smoking. And also increasingly, we're finding out that vaping is important in this regard as well, and something that we need to really think about speaking to young people about. So these are the types of things that can impact on cardiovascular health. And I suppose making that clear at an early stage so that people think about their, learn habits and lifestyles at an early age that will then probably stick with them for life. Obesity is an important one in cardiovascular health. So in Glasgow, where I'm based at the moment, we know that by the time patients leave primary school, so around sort of 12 years of age, about 33% of children in Glasgow are already obese, and there's really an obesity epidemic around the world. Obesity is important on lots of levels. One, it's linked to things like type 2 diabetes. It's linked to poorer cardiovascular outcomes, heart attacks, strokes and things over the long term. There's also a lot of research to show that the actual cells, the adipocytes, the cells that are present within fat, might be what we call sort of metabolically and immunologically active. So they might also be driving inflammation in some way by producing some of the same sort of cytokines and things that are a problem in the joint. So they probably, it impacts probably on the actual disease itself, and it impacts on longer term. So we really need to think about obesity in the context of pediatric rheumatic diseases. And doing these things to help protect heart in children can reduce the risk in adulthood. Bone health, I mentioned at the beginning, is also something that we need to think about. So there's a couple of reasons why we need to think about that. So one is that with inflammation, that can impact on bone density. So by bone density, I mean like the strength of the bones, how dense it is. If you think of like a sponge, there's lots of little holes in it. Bones are a bit like that. If your holes are bigger, then that's more of a problem than if the holes are smaller and the bone's more dense. So inflammation can affect bone density. Steroid treatment in particular, long-term steroid treatment, is something that we know impacts on the bones, and sometimes we need to start monitoring the bones when people have been on steroids for a very long time. And being inactive also impacts on the bones. So your bones really need weight-bearing exercise. They need to be stimulated in a way to be able to keep the process of laying down bone and reabsorbing old bone. That's something that has to keep happening all the time. And if you don't, if you're inactive, that can impact on that. So the things that we can do to help support the bones and prevent bone disease are weight-bearing activity and impact activity. Making sure that calcium and vitamin D levels are fine. I often congratulate patients when I see a normal vitamin D level, because it seems that everyone has a low vitamin D. And we know that vitamin D plays a part in all sort of parts of the immune system, but also is really important for bones. We need to minimize steroid exposure, knowing that obviously sometimes they are needed, but where possible, trying to minimize it. And then particularly in patients who have maybe had a lot of steroid over a long period of time, we need to be monitoring, doctors need to be monitoring bone health and thinking about doing things like DEXA scans, which look at the density of the bone. If it's found to be below a certain level, there are treatments out there that can help with strengthening the bone, called bisphosphonate treatments, things like pamidronate or zoledronate, that can be used to try and treat this. And childhood is a really important time period for laying down bone. So in everyone, all bone is laid down gets as strong as possible up until your sort of early 20s. And then from then, we're all sort of losing bone. So in your 30s, you've got less bone mass than your 20s. In your 40s, you've got less bone mass than your 30s, and it just goes on like that. So this period of being a teenager is actually really critical for building bone strength and reserves. And then thinking about infections is important. And there are, usually in rheumatic diseases, we're talking about an overactive immune system, which is attacking the body and causing the different manifestations. And the treatments that we use are trying to sort of calm that down. And it's far more risky to have uncontrolled inflammatory disease than it is to be on these treatments in the vast majority of cases. The things that we can do to try and prevent that are things like making sure that our vaccinations are up to date. So making sure that your child has followed all the sort of routine vaccines that are recommended within the country, thinking about things like flu vaccines, COVID vaccines, chickenpox vaccines potentially, and then when there are signs of infection, seeking medical support at an early stage to get assessed and think about whether or not there's any need for any specific treatment for those infections. Making sure that people around know of these, the importance of this, particularly school, the teacher being aware that not to have your child sat next to someone who's clearly full of a really heavy cold for 8 hours in a school day. And just being sensible really and aware of this, not using it as we still want children to lead completely full and active lives, and we don't want them to stop them from doing anything, but everyone should be sensible really. And then mental health and emotional well-being. So I often speak to young people about the fact that for everyone, regardless of whether or not they've got a paediatric rheumatic disease, this will probably be an issue at some point. It's very unusual for people to get through the whole of their life and not have at least some, need for support at some point. And obviously it's a spectrum. But things like anxiety, low mood, fatigue are very common in paediatric rheumatic diseases. Often people feel that it's like a weakness or something that they can't speak about, but actually if you try and normalize it and mention that these are something that you will run into at some point, and we want to know when you do so that we can help you, is really important. And making sure that people are aware of the interventions that are out there and who they should contact. So trying to access support early, it's one thing having a psychologist at the hospital that you can sort of touch base with intermittently, but sometimes it can be really helpful to have someone in the closer environment who can be better placed to deal with crises as and when they come on, and often that's through school. A lot of schools have maybe somebody who provides pastoral care, or even counsellors within schools. So linking in with different types of support that can support at different times can be very useful. And often your sort of structured psychological support will provide a lot of structured support and toolkit that young people can use when dealing with different situations. And school-based things will maybe provide help with more sort of crisis management and stopping things from escalating, or providing sort of practical tips on how to sort of see the way forward. So both have got a role, and one of the most important things is making sure that it's an open conversation and people don't feel ashamed to speak about mental health, because it's just as important as physical health. Reproductive health is something that obviously isn't of importance of all young people. It's usually the teenagers more that sort of worry about it a bit more. But being unwell with a paediatric rheumatic disease, particularly if it's more of a sort of one with a very high level of inflammation and sort of more of a systemic disease, can cause periods to stop for a while. It might make them irregular. Often, a lot of our diseases can come on in teenage years, and periods can be irregular already, just as part of the norm. So some of it may be just periods sort of settling into a normal period. Some of it might be being unwell and your body just focusing on other things rather than periods, and sort of temporarily stopping having them. Steroid treatment can also affect regulation of hormones, and all the things that make you obviously have periods and reproductive health are all to do with hormones. There are certain medications that can affect things like the timing of puberty. So cyclophosphamide, which is a type of chemotherapy that's used when someone's got quite a severe manifestation of a rheumatic disease, can affect the timings of puberty. It can delay it a little bit. It can affect the regularity of periods when you're on it, and it can bring the onset of the menopause potentially a bit earlier. But generally, this relates to the cumulative dose, so the amount of medicine that somebody's had over the whole time of their life, and we've increasingly tried to keep that lower and lower through using different regimes. And if somebody gets cyclophosphamide before they've even gone into puberty, then the risk is lower than if they get it after puberty. So there's a few, so it's definitely not the case that if you've had cyclophosphamide that any of this is going to happen, but it's something that people need to be aware of. As people are going through transition, we start thinking about, if you were to become pregnant, that there are certain medications that must be avoided in pregnancy because they can impact on the baby. When patients are in adult rheumatology, it's really important to have that conversation with your adult rheumatologist. And often when people are planning for pregnancy, they might be referred to a specialist obstetric clinic just to talk through it and to think about the things that would be helpful. I think the main message that adult rheumatologists will always give is that it's much better to, plan a pregnancy when you're on certain medications, or if you've got a paediatric rheumatic disease that can impact on reproductive health. So keeping that dialogue open. There are a type of antibodies that are seen in certain conditions, particularly things like lupus, that can impact on pregnancy as well, and you might need certain treatments to try and help in pregnancy. So that's really important to be aware of and to discuss with doctors. This is mainly focused on females, but also boys need to avoid certain medications when they're planning for a family as well. So again, the importance of having that conversation with their rheumatologist. And I think prevention is really a team effort. A lot of what we've spoken about is things that happen outside the hospital setting, outside the clinic, that can impact on longer term outcomes. So I think families are, probably the most important in this, but also, speaking to healthcare teams, thinking about these things in advance, raising things during consultations, speaking to others in charities and getting advice as well. And it involves, the doctors, but also physiotherapists, psychologists, dietitians, primary care are all very important in this. And getting some of this information in during transition, I would say, is very important to help with empowerment and thinking about their condition over the lifelong term. We have done some work asking young people with rheumatic diseases about what they want us to be looking at. So in Liverpool, we were running a study as part of a PhD programme, looking at data that's been collected in primary care across the UK using this sort of database called CPRD. And before sort of even doing that study to look at longer term outcomes and comorbidities, we wanted to ask the young people what they thought we should be looking for. So there's a whole load of things that we could look at, but we wanted to know from them what they wanted us to try and pull out. And this is still ongoing work, so I don't have any results to show to you, but the things that they told us they wanted us to look at are mental health. 94% of participants, again, emphasising the importance of that. They were also interested in us looking at the impact of obesity and the impact of the rheumatic disease on heart disease, stroke, and infertility. And we did talk about when they want us to speak about comorbidities and long-term outcomes. And they said that although it was scary, that they did want information on this. They wanted to know information about the risks, but in a sensitive way. And that if they had that information, it could help them to make lifestyle changes as long as there was some support to make those changes. And that, increasingly they wanted digital ways to be able to get that information and to be able to support them over the longer term. So the key take-home messages are really that there are what comorbidities are, that they're common, but they're not inevitable, and we can do things to influence the course of the disease, that prevention and thinking about the disease beyond the joint or beyond the muscle or skin is really important. That it's important to think about the heart, to think about bone health, infections and mental health really as part of routine care rather than thinking of these as additional things. And that impacting on this is really a team effort involving clinicians, families, young people, all as partners together. So thank you very much. I hope that was of interest, and welcome any questions at the end. Thank you.
This presentation explores the hidden complexity of comorbidity in juvenile rheumatic diseases. My name is Sean, and I'm here today not as a medical expert, but as a parent of a daughter with juvenile rheumatic diseases, and with that, comorbidities. She was diagnosed at 4 years of age and now a young adult at 19 years old. I'm also a mom of 3 children. When your child is diagnosed, you learn a new language, inflammation, medication, flare-ups, and so on. But what no one prepares you for is the complexity behind the diagnosis. The fatigue, the anxiety, the sleepless nights, not just theirs, but also yours. Comorbidity isn't just a medical challenge. It's a daily reality, one that requires more than flexible treatment. It requires flexible minds and hearts. Next slide. Can you do it, Michael, or please?
Yes, of course. 1 second. There we go.
Thank you. Gia Neville rarely travels alone. When your child is diagnosed, you feel relief, and finally you've got a name. But very quickly you realize that the diagnosis is just the tip of the iceberg. You're not just dealing with joints, you're dealing with everything else: eyes, emotions, energy levels, and sometimes even attention and behavior. Comorbidities don't always announce themselves. They sneak in quietly, and if you're not watching closely, they get missed or misunderstood. Children with chronic conditions carry invisible weight, like you see in the backpack: fatigue, fear, anxiety, also missed milestones, sensory overload, and much more I think everyone can relate as a parent. Parents carry one too, filled with worries, logistics, and emotional strain. We become translators, advocates, and coordinators. One day, my daughter goes to school and she looked fine. She smiled and she went to go to see her friends. But just after 1 hour, her energy was gone. The teacher called us if we want to pick her up. I have to drop everything. And we went to pick her up, of course. Not because of the pain, but because of everything else. The invisible burdens affect school, mood, and daily life. This backpack isn't visible in the waiting room, but it's there, every day and every step. As a parent, we learn to read the signs others doesn't see. We know when fatigue is more than tiredness, when silence means anxiety, when a smile hides a storm. Some examples we can see is fatigue and sleep disturbance that impact school, friendship, and self-esteem. Mental health, like anxiety, depression, from uncertainty and isolation. The medication side effects, like bone density loss, mood swings, and weight changes. You can also have autoimmune overlap with skin issues, and you have to see some multiple specialists. Cognitive fatigue, like brain fog and learning difficulties. Also social withdrawal, reduced participation, and often misread as disinterest. As parents become translators of our children, we see the subtle signs others miss, the weight of invisible symptoms. These comorbidities shape our children's lives and ours, and unless we name them, they stay invisible. Can you please do slide 3, Michael? Thank you. Comorbidity in daily life and family impact. It means more than one challenge at a time. It's not just a disease, it's everything around it. It means multiple specialists in different hospitals. It means choosing between school, rest, or yet another appointment. It means uncertainty and adapting constantly. And it affects the whole family. Parents juggle work and caregiving and uncertainty. Your own needs don't get attention because of overwhelmed feeling and exhaustion. Last minute, some plans get cancelled. You're constantly living in a survival mode. Siblings feel this shift. They are feeling overlooked. Sometimes in a family there are more diseases. There is loss of normal routines and invisible emotional labor. With the school pressure, there's also social withdrawal. Sometimes the comorbidity becomes the bigger challenge than the disease itself, not because it's more dangerous, but because it's more constant, more invisible, and more misunderstood. We too learned that comorbidity requires more than medical care. It calls for emotional resilience. Can you do slide 4 for me, please, Michael? Thank you. The maze of care. We don't just manage symptoms, we manage systems. Comorbidity doesn't mean more systems, it means more. Comorbidity doesn't mean more symptoms, it means more systems. Our child sees multiple specialists, often in different locations. More appointments, more portals, more paperwork. We chase authorizations and explain our child's story again and again. So we become the coordinators, the planners, and the bridge between care. We become the central hub in a fragmented network. One specialist treats joints, another the gut, another the eyes. But no one sees the whole child, except us. We learn to speak the language of each department, and we translate it into something our child can understand and live with. We manage medication schedules, school communications, insurance forms, and care plans. We coordinate between hospitals, therapists, and teachers, often while holding down jobs and caring for siblings. And every day we ask ourselves, what's most important today? And what can my child and I handle? What does my child need, and what do I need to keep going on? This isn't just parenting, it's case management. And it's invisible unless we name it. Comorbidity isn't rare, it's reality. From eye inflammation to gut disease and skin issues to immune complications. Parents don't just manage one diagnosis, they navigate a web of overlapping needs. In this maze, we become the quiet experts, not because we choose it, but because our child needs it. Michael, do you want to do the slide, please? Thank you so much. What helps? Recognition, flexibility, and systemic change. What helps families? As you see on the left, the multidisciplinary care, not just one specialist, but a team that communicates. Listens to the child's voice. They are more than their diagnosis. Trusting parental observations. We often notice the first subtle signs. The physiological support. It's not optional, it's essential. The peer supports. Family change, sharing stories, strategies, and strength. Open communications between families, schools, hospitals, and professionals. And celebrating good days, not just lab results, but moments of real life. On the right, what the system has to learn. Care pathways must reflect comorbidity, not just the primary diagnosis. Professionals should ask, what impacts your daily life the most? Co-creating materials that include fatigue, mental health, school stress, and emotional resilience. Seeing the whole child, not just each organ or symptom. Integrating physiological and social care as a standard part of treatment. Let's build systems that see the whole child and the whole family. Do you have the next slide for me? Thank you. Growing together, even with complexity. Families are resilient. We adapt, we advocate, we endure, but we also dream of something more. Children can thrive, not just survive, when they are supported in all dimensions, physical, emotional, socially. And that support doesn't come from one person or one system. It comes from partnerships between parents, patients, and professionals. We have learned to navigate the maze, to carry invisible backpacks, to read the signs others miss. But we don't just want our children to survive their disease. We want them to live well. That means being seen, being heard, and being supported, not just in the clinic, but in school, at home, and in society. Thank you for listening and being a part of the change. The next slide, yes, thank you, Michael, is this slogan. We want our children to live well beyond the boundaries of the disease. Thank you.
Good morning. I'm a psychologist in Greece, and as a psychologist, I would like to share some reflections on the comorbidity of GIA with other disorders, and to focus on the psychological and emotional dimensions that so often shape the experience of these young people and their families. GIA is the most common chronic rheumatic disease in childhood, affecting approximately 1 in 1,000 children. Although it is primarily a medical condition, it is in reality a life condition, a disease that influences the child's emotional world, the family's dynamics, and the way both perceive the future. When we talk about comorbidity, we refer not only to overlapping medical diagnoses, but also to overlapping borders, physical, psychological, and social.
Sorry, Margarita, if you could tell me when to advance the slides, please, so that we're both in sync. Thank you very much.
You can, yes, you can change it. GIA may coexist with other autoimmune conditions, such as systemic lupus or juvenile dermatoleucitis, and sometimes with non-rheumatic disorders, such as autism. Each of these comorbidities adds a layer of complexity to both the clinical and emotional management of the disease. Children with GIA experience chronic pain, fatigue, stiffness, and unpredictability in their symptoms. This sense of uncertainty can generate anxiety, irritability, and over time, depressive symptoms. Many children struggle with emotional regulation because their pain is invisible to others. They can't recognize it. They often hear comments such as, but you look fine, which deepens their sense of isolation. They may feel different, limited, or misunderstood by their peers. Especially in adolescence, this becomes even more challenging. Body image, independence, social belonging are central concerns during this age. A young person who cannot participate fully in sports or social activities may feel left out, frustrated, or ashamed. Some adolescents begin to resist to their treatment as it's the way for them to reclaim control. It's a form of silent protest against their condition. Can you change the slide, please? Then families also live with this disease. Parents often experience anxiety, guilt, or helplessness. They may question whether they did something wrong or feel torn because being protective and encouraging affect their own lives as well. These siblings sometimes feel neglected or jealous because of the attention that the other child receives. This can disrupt family balance and communication, and financial and social stressors add to the emotional toll. Frequent medical visits, treatments, and unpredictable flare-ups can make normal family life difficult, and we have interruptions to the normal life. Empowering families to manage uncertainty, to communicate openly, and to support one another is a central part of therapeutic work. Adherence to treatment is another key challenge. Can you please change the slide? Children and adolescents must cope with long and sometimes painful medical regimens, side effects, and a sense of control. Non-adherence is not just disobedience. It is often a message of fatigue, frustration, or fear. Can you please... Okay. Psychologists can help by addressing these emotions, improving motivation, and building a collaborative relationship between the family and the medical team. The school environment plays a critical role as well. Teachers and peers can either be powerful allies or sources of stigma. When schools are informed and flexible, they can provide spaces for participation and inclusion, even when physical limitations exist. Psychologists often act as mediators between the family and the education system, promoting understanding and empathy within the classroom. Can you change the slide? At the heart of all this lies the multidisciplinary approach. Can you change the slide, please? Rheumatologists, nurses, physiotherapists, occupational therapists, psychologists, and social workers, we all work together. We share the same goal, to see the child not only as a patient, but as a person with emotions, dreams, and resilience. Psychological care is not an optional luxury. It is an essential component of an holistic treatment. Psychological interventions take many forms. Can you change the slide, please? Individual therapy helps children develop coping skills and manage pain-related anxiety. Cognitive behavioral techniques can reduce catastrophizing thoughts and promote adaptive behavior. Family therapy fosters open communication and strengthens resilience in family. Group interventions, especially for adolescents, help normalize the experience and reduce feelings of isolation. And creative modalities such as art, music, or relaxation therapies allow children to express feelings that words cannot capture. Can you change the slide? Let me share two brief clinical examples. The first concerns a 9-year-old girl diagnosed with GIA and systemic lupus. The family was exhausted and overwhelmed. Through family psychoeducation and emotional support, they gradually learned to communicate more effectively, and to balance medical vigilance with normal family life. The second case involves a 13-year-old boy with GIA and autism. The integration of structured communication strategies and parental training significantly improved his cooperation with treatment and reduced his anxiety during medical visits. These examples illustrate a broader truth. When psychological care is integrated into the medical framework, outcomes improve, not only clinically, but also emotionally. Children gain confidence and resilience, family regain hope, and the entire care process becomes more humane and sustainable. Can you please change the slide? In conclusion, comorbidity in GIA is not merely a medical issue. It is a biopsychological reality that requires a comprehensive approach. Addressing the emotional needs of children and their families is a fundamental to achieving adherence, resilience, and a better quality of life. By working together across disciplines, we can offer these children not only longer lives, but fuller, more meaningful, and more joyful. Thank you very much.
And so now that was our final speech for that section. So we're going to bring it all together for a quick panel discussion. If you have any questions, please do let us know in the Q&A. Thank you all for your presentations. I think we've had quite a diverse perspective, and the ability to have a clinician, a psychologist, and a parent voice is actually really valuable. So if we go back to the start with Eve's presentation, this is a theme that actually came up across all three of your presentations, is this idea of managing comorbidities in multidisciplinary teams, and the idea that we have different specialists working to coordinate a child's care. So what I would like to know is that from a clinician's perspective, at least what I have often seen is that sometimes physicians are not aligned on their approach. So you may go to your rheumatologist and they have one strategy, and then the gastroenterologist gives you something different, and that may compromise the JIA, and it gets quite complicated in order to coordinate that care. So presumably it's better to be working in this team setting. But how can we improve the logistics of this? How do you approach this as a clinician? And is there anything that we can do as patients and parents of children with rheumatic diseases to help and streamline the process?
Yeah, so I can see that would be difficult and confusing, I suppose, for patients and families if you're getting different bits of advice from different people. I suppose in an ideal world, the clinicians should all be communicating, and they should be having those sort of conversations. And I suppose sometimes there can be sort of organizational barriers. So you might be seeing one type of clinician in a certain hospital, you might be seeing someone else somewhere else, you might be seeing specialist care in one centre and something else somewhere. So there's a lot of barriers. And I suppose this is where it's very important that the clinicians and the different members of the MDT and the patient and the family all work together. And I suppose the families do play a role in sort of helping to orchestrate that and sort of calling out when they're getting different bits of advice, and maybe suggesting that people try and communicate. And it's not unusual for us to try and have MDTs where we pull people together and sort of communicate together. And sometimes ideally they're driven by clinicians doing that, but there have been times where families have really raised this, and this has prompted healthcare teams to sort of call together clinicians maybe from different hospitals. You might have someone coming to one hospital for their GIA care, but then have a local paediatrician locally who's dealing with other things, and then maybe a respiratory specialist in a different. So I think when those things are happening, and it's clear to the family that this is difficult, and people aren't speaking, they need to try and call that out. And it might not be comfortable to them to be able to do that, but sometimes the clinician might not realize the impact that that's having. And there's certainly been times where on the basis of a family saying to us, this is really difficult, where this information is being, things have improved for the family, or we've called an MDT, we've, shared information better. And I suppose, the more complex the condition and the more teams involved, the more difficult this becomes. And often we, need to seek advice, and people need to be seen in a different centre because there's a specific level of expertise, but the communication isn't always brilliant, and we all tend to have different electronic medical records. So these are problems that we need to try and tackle. I'd definitely say that we're not there yet, and there's a lot of barriers, through digital platforms and all these types of things that make that difficult. And I suppose calling it out is the thing that you can do to try and make the clinicians aware that this isn't working.
Fantastic. And I think that's really helpful for everyone to hear the clinician approach to that. Something I'd like to ask John is really from the parent's perspective. How do you deal with the fact, and everyone is welcome to jump in on this, but how do you deal with managing where your child appears to be fine on the outside, and as we've discussed, this invisible backpack of symptoms occurs? Do you have any strategies for parents who may be struggling to remember that the child is still affected by the condition, even though it's invisible, or maybe that the child is in pain, and any tips for recognizing where that may be from your parental experience?
Just to make sure that as a parent I recognize the pain and if in my child, or if I have to talk about it with others.
Yeah, are there times where maybe your daughter appears to be fine, but if underlying she's really struggling, and have you ever had that, and how do you spot that?
Of course. Well, I think you spot it automatically in the time being. It's something my daughter is now 19. If she walks beside me and I see when her knee is hurting because she walks differently, but it's not that I see it, I look at the knee, but it's just you feel it around you when your child is not having pain or having fatigue. So of course, but I also learned in the long run that it's not always needed to be called immediately to the rheumatologist. So she's having fatigue or pain. That's what was my first quick response in the beginning of the period, because I had no clue what it was like, what GI was. So, but now we know it's a daily life. So I don't know the tips. Well, we explain it to our friends and in a circle, of course, and also the friends of my daughter also knows about it. But she's learning the hard way that friends come and go at this moment when it's mentally not going well with her. So it's a more collaborative answer than you asked me, Kabir, but
no, that's great. That's what we're after. And I think to Margarita now, I think from what we've seen in terms of, you've spoken about CBT and alternative methods of treatment. What do you do in the scenarios where CBT is maybe not the most effective strategy for a patient, and maybe they're at this stage where they're trying to vent about their condition, and they may struggle to speak about their condition? Do you have any alternative ways of helping a child through that perspective?
Of course, we have therapeutic techniques addressing the emotions, the expression of emotions, of difficult and negative emotions that the child may have. Expression through paintings, through music therapy, through relaxation techniques, peer groups for expression and sharing their experience. Most of all, techniques of emotional regulation.
That's great, because I think a lot of people don't often think about the role that music and art and relaxation may actually play, and it's something that is really accessible, even from a more informal lens, to give that breadth of mental health treatment as well. There's a question here in the chat from Marco, specifically for Eve. I'm going to read it. It says, as was mentioned, medicine for rheumatic diseases can have a lot of unwelcome side effects and possible causes for some comorbidities. Regarding this year's Nobel Prize in Physiology and Medicine and the discovery of cells that keep immune responses in check, how important is this discovery in regard to the search for more effective medication for autoimmune diseases in general?
What a great question. So I think, research is constantly evolving. It's great that there's, that this has been recognized with a Nobel Prize, and hopefully, these will move their way through to children sort of sooner rather than later. We do know that there is a delay between, treatments being developed and tested and thought about and used in adults and then being used in children, which is unfortunate and is something that we try and tackle. And we're trying to really push that actually children and young people should be considered for inclusion in studies earlier so that we can get access to these treatments, because really it's fairly shocking how long it takes for treatments to get through to children. I think that, that we have got a lot of good treatments in pediatric rheumatology already. Even for conditions where for years we haven't had any new treatments coming through, things like conditions like lupus, where things weren't changing for quite some time, and now we've got a number of different options. I think, hopefully cellular therapies, we've heard a lot of success stories and of CAR T in adults, and now increasingly in children with lupus, with JDM, with systemic sclerosis. And these are trials that are happening at pace, really, and children and young people are being included sort of much earlier than we would have maybe expected traditionally. Often because they've got most to benefit from these treatments. So getting in there and treating early, and preventing damage is really key. So I think the future is bright. I think things are evolving at pace. I think research is extremely important. And if we want to move things forward, we can't do that without research. I think, patients and parents and organizations play a really key role in pushing for more research and trying to support researchers. There's a huge difficulty across the world, I would say, in people committing their careers to medical research, and they really need the support of people like yourselves to try and really emphasize the relevance of that and why they should keep going, and also to make the case with things like funders and governments about the importance of this. So I think we all really need to work together if we want to move forward our understanding of these conditions, and in particular, develop new treatments.
Absolutely. I think that's a brilliant answer, and very nice to have a clinical perspective on those developments as well. So this question, I think, is best for John and Margarita. It would be really nice to have each of your perspectives. But in your experience, do you have any suggestions in helping the child, the patient, tell their friends or their school system or circle of people about their condition? And maybe we can look at this from a younger child's perspective and then a young adult perspective. It would be great to hear from both of you on this one. You're welcome to jump in.
Well, as an example of a young, when she was really young, we did at school. We had a school products, and I thought it was from the GVN patient organization in the Netherlands, to explain to them in the classroom what the condition is on child level. They also wrapped around like a knee or a joint or like a finger, or so they can feel a little bit how it's when it's closed. Then you don't get to use your joint, and you walk down the stairs with your knee all tied up. how it feels a little bit to play in the school yard. So I think that was a good idea. So go to patient organizations for maybe they have some kind of things that they can translate it to school. And as a young adult, I would say it's really up to them. As a parent, you have to be a wallflower, I always says. You have their back and you have the support, but they are in charge if they want to talk about it or not. But most of the times, I think along the years, they have become their own advocacy really well. So
fantastic.
I totally agree. If I can say, the younger the child, the adults have to take care of this psychoeducation that needs to take place, especially in school. Psychologists, teachers have to psychoeducate children about every possible difficulty that children may have in school. And in adolescence and young adults, they have to accept their condition. They have to learn how to present themselves with this general story. They have to include their difficulty in their self-image and in their life. And not be ashamed and not be shy to be themselves.
Absolutely. And a follow-on question we've had in the chat for you, Margarita, and maybe Eve as well, from those perspectives is, from which early age is it advisable to get a specialist on the emotional challenges for your child?
The earlier the better.
The earlier the better. Okay. I think that's a really valuable one as well. Eve, do you have anything?
I suppose just also making families aware that it's an option, and that it's there, and to reach out when they have a problem, and they might not, it's just raising it as that it is a very common issue, that it's not any way, unexpected, and they might have some contact with someone, a psychologist, and they might then feel that they're okay, but just knowing that person is there and how to contact them can be very empowering and sort of reassuring for them, even if they don't embark on a long sort of course of involvement with a therapist.
Absolutely. And I guess a follow-up to that comment is, I wanted to find out if any of you, either Eve or Margarita, work with a doctor or psychologist or medical social worker, if you know what I mean, in your combinations of roles. So like you may actually work with a specialist, and then that psychologist comes back to you, Eve, and has a conversation about how the patient is currently looking. Is that something that is done over where you are? And what do you think about that concept?
Yeah, so we have fairly regular, what we call psychosocial MDT meetings, where we're joined by psychologists, we're joined by an art therapist, we can be joined by other therapists who've been involved with the child, and we discuss the children sort of more holistically. I think there's huge inequity in access to psychologists and in access to members of the wider sort of MDT. So I think it can be really tricky if you're somewhere where there isn't easy access. And I suppose that's where increasingly I think we'll be looking towards, digital tools and things that can help at an early stage. And there are projects like the one led by Polly Livermore in London, where she's developing a digital chatbot to try and help support MDT. So to try and support coping and mental health. So I think there will be different ways to approach it. It won't always be that the traditional model of seeing a therapist, although ideally everyone would have access to therapists, but it's just not always available for all people. So I think we need to make more of an effort to make it equitable by having a range of different options, really.
Absolutely. I think the equity aspect of most of public health in general is really challenging at this time, because AI, as amazing as it appears, has many pitfalls, both from a clinician's perspective and from a psychological perspective. And so obviously, ideally, we'd all have access to the doctor and psychologist, but it is going to be interesting to see how this evolves over time. Thank you all for this fantastic session. It was lovely to hear each of your perspectives and to have this panel discussion. We're now going to head into a 10-minute break that is going to take us to 10 minutes past 12, 12:10. Thank you once again for joining us.
Thank you.